أول شيء صباح الخير. Good morning. Thank you, Doctora, for the introduction. It's always a pleasure to be around renowned and inspiring doctors, and thank you for allowing me to be part of your outstanding international conference in Bahrain. Of course, I love Bahrain. I was talking about Bahrain. It's close to my heart. I think it's my second home. Well, today I'm going to be giving my first talk. I have two talks. Today, I'll be talking about hypertension in diabetes, and tomorrow I'll be talking about diabetic nephropathy or update in diabetic nephropathy. So if you allow me, because of the overlaps between the two presentations, I'm going to concentrate today on hypertension per se and leave the nephropathy for tomorrow. Now, I arrived late yesterday, and honestly, I did not get the chance to sleep. So I went over my presentation, and I was thinking that I'll be giving the presentation to the gurus of hypertension and diabetes and even nephropathy. And it's true, because a recent study have shown that you follow and treat and manage patients with hypertension and nephropathy more than nephrologists themselves. So without further delays, we'll start to go over the objectives of my presentation. So I'll start to make the presentation a little bit attractive, alluring, and more interesting and engaging. I wanted to go over the hypertension history, and then we'll go over the benefits of hypertension in diabetic patients, and then we'll try to talk about the targeted blood pressure in patients with diabetes. We'll talk about the disputes and the differences in the guidelines, and I promise you at the end of that part of that lecture that there we'll agree, all of us, that we're all talking in the same page, and there is not much of a dispute or a differences in the guidelines. Then we'll talk about the core treatment of hypertension, which is the ACE inhibitors and ARBs, and if we have time, we'll talk about resistant hypertension and future hypertension, of course, and digital technology. Okay, so hypertension, it's been there for centuries. And the treatment of hypertension at that time, actually it wasn't considered as a disease. It was phlebotomy and even using leeches. And the surprising thing that this continued until 100 years ago, in 1930s, that understanding was still valid. In 1931, Dr. John Hay, who's a professor of medicine at the University of Liverpool, stated that the greatest danger to a man with a high blood pressure lies in its discovery, because then some fool, and I think he meant us, is certain to try and reduce it. Now, this was echoed by Dr. Paul Dudley White in 1937, as saying, hypertension may be an important compensatory mechanism which should not be tampered with, even if we were certain that we could reduce it or control it. Meaning that the understanding of hypertension was not valid. The thought it was related to stress. Now, this continued until 1945, when Dr. Charles Frederick discovered that if you lower the blood pressure, you actually can lower the risk of the cardiovascular event, stroke, myocardial infarction, heart failure, and left ventricular hypertrophy. And why I'm saying this, why this is important, because you're all aware of Franklin Roosevelt, who died in 1945 from hemorrhagic stroke that was directly related to severe hypertension. Now, if this article or that statement of Dr. Charles Frederick was earlier, then possibly Roosevelt would not have died, and Truman would not have taken over, and bombing of Nagasaki and Hiroshima would not have happened, and probably the world political history would have changed. And I brought this to make it as a joke to start my talk about high blood pressure. So from that on, the understanding of lowering the blood pressure was an important fact. Now, my second part is I'm going to take a turn and add to the high blood pressure diabetes to make it to understand why it is important to lower the blood pressure in diabetic patients. And obviously, we've all seen patients with type 2 diabetes and type 1. Majority of our patients, they present with what? With 60% with them, they present with hypertension. And actually, if they have a rise in serum creatinine or microalbuminuria, the hypertension can be in 80 to 90% of the patient. Again, with type 1 diabetes, later on they develop hypertension. Hypertension with diabetes usually is the resistant form. 40 to 60% of them, they become resistant, and around 3% become refractory hypertension. And most importantly, that if you add hypertension and diabetes, and I call them the dual terrorist for the cardiovascular disease, actually you will increase the risk of cardiovascular event, not by once, twice, or three times, but as you can see in this graph, it can go up to 8 times, meaning if you have a patient with a systolic blood pressure of more than 170 and present to your clinic and he has diabetes, if you don't treat that patient vigorously, then you would definitely see this patient within 6 months to 1 year with an acute cardiovascular event. Okay. Now, other studies have shown that if you have high blood pressure, the risk of cardiovascular event is still high. You can see even in the HOT study, the higher the blood pressure, the diastolic blood pressure, the risk or the overall cardiovascular risk factor is still higher. And even in the Murphy study, the systolic blood pressure compared from diabetic to non-diabetic, if you have high blood pressure, the risk is high. So the concept of lowering the blood pressure is agreed by everyone, by all societies, by every doctor in the world. The second question is, what should be the blood pressure target in diabetics? And I'm sure you all have been to many conferences, ADA, the American Society of Nephrology, European Heart Society, every one of them have a different guideline. But if you look at the prints, the small prints, or in between the lines, I think we're all talking about the same page. But let's start with this. If you look at most of those studies have proven that if you lower the blood pressure to below 140, targeting 130, you will benefit from lowering the blood pressure to that level. And if you do a meta-hoc analysis, of course, this is the SHEP, the CIS-Euro study, the HOT, the United Kingdom prospective study, the ABCD, and all other studies, all HAT study have shown the same. But if you do a meta-hoc analysis, meaning if you analyze those patients, you will find that if you go below 30, you will benefit the most. Now, this was echoed to give us those previous guidelines. If you all recall, the blood pressure, even the ADA, was recommending 130 below and 80 below. And most of the studies have shown that if you target that blood pressure, things will be, the cardiovascular events will be much better. Of course, this depended on those studies. This is one study called the HOT study, and I'm sure you all know them, where they looked at diastolic blood pressure. The lower the blood pressure in the diastolic arm, between 90 to 85 to 80, so the lower the blood pressure, the better outcome. Of course, this is the advanced blood pressure trial. And why I did include these trials, there's other trials, because there's two things I want you to notice. Of course, they looked at the standard blood pressure and the intense blood pressure. The standard blood pressure meaning targeting 140 to 130, and the intense targeting 130 to 120 and lower. But if you compare both of them, and if you look at the number of medication used, you can see that in intense blood pressure, they use around 3 to 4 medication compared to the standard, which is 2 medication. And this is important, it becomes important for governments, because we're talking about hypertension. There are more than 1 billion patients with hypertension, so cost effectiveness becomes an issue. Another careful one. And this is again, this is the study, the advanced trial, showing that all cardiovascular events, macrovascular or microvascular, definitely if you lower the blood pressure to the intense part, you will have a better outcome. And again, this is the United Kingdom prospective study showing the same. So the question is, and this is the important part, how low should we go? How low should you go with your blood pressure? And this is important because after that, we had this study. You're all aware of the ACCORD study. And the ACCORD study looked at the intense blood pressure compared to the standard blood pressure. And in the intense, they looked at blood pressure targeting 130 to 120, and the standard, they looked at 140 and below. And what they found that in the intense blood pressure part, actually the benefit was not valid. Meaning if you go below 130, there is no added benefit. Of course, there is a lot of criticism in this study, although I believe this is a good study. The criticism was because the number or the power of the patients, the power of the number of the patient was not high. They excluded the dyslipidemic arm, and actually the average age of those patients was 62 compared to others 68, and they excluded patients of more than 80 years old. Meaning, in that ACCORD study, if you look at it actually, and you do a meta-hoc analysis, you'll find that they actually looked at low-risk patients. And majority of the patients who did not benefit had initial blood pressure of around 136, 137, which for us, it's still a low-risk patient. But if you look at those patients in the ACCORD study who initially had a blood pressure above 140, they showed that there are some benefit, but of course the power was not high to show the importance. Now this is continued, and as you can see, the ACCORD showed there was no added benefit of lowering the blood pressure. Of course, this is confusing because then we get the SPRINT study. Of course, it's not in diabetic patient, but the SPRINT study was clear. If you compare the standard blood pressure 140 to targeting 130 to the intense 130 targeting 120, then you have overall the comorbidity and the cardiovascular morbidity was lower. But this is confusing. So what do we suggest? Now the ADA recommended 140 over 90, but at the end they added an amendment to it. But the SPRINT became clear for the different societies that the target should be 130 below 80. Now, the heat behind those two studies was so clear in the last 2 years. But let me show you previous studies. This is the on-target study. The on-target study, I don't know if you remember the on-target study, but the on-target study was 100,000 patients where they looked at telmisartan combination with ramipril and each one alone. And if they looked at the overall outcome, when you lower the blood pressure with the telmisartan group or the combination group, there was no added benefit. So even with the on-target study, the telmisartan group and ramipril, when you add them and you lower the blood pressure below 130, there was no added benefit. On the contrary, some of them had an acute insult to the kidney and hyperkalemia. Right. To make things more confusing, I'm sure you know the PROF study and the PROGRESS study. The PROF study talked about telmisartan and in regard to recurrent stroke. Now, if you look at the study, the PROFs showed that if you lower your blood pressure to below 130, your risk stratification or your risk of getting or lowering the stroke was not valid. Actually, there was no added benefit. But if you look at the PROGRESS study where they used ACE inhibitor, the penodepril, actually there was a decrease by 37% in the stroke risks. Yani, this is a little bit confusing, especially not only to us, but also to the patient. You look at the TRANSCEND study where 37 of the patients were diabetic. Again, there was no added benefit. To make things more confusing, you look at the INVEST diabetes study, and which you're all aware. If you look at the coronary insult, if you lower the blood pressure below 130, there was no added benefit. And the HOPE trial, when you add candesartan with hydrochlorothiazide, it did not show an added benefit in lowering the blood pressure. But what does that mean? Does that mean we need to continue 140 and forget about the 130? The answer is no. Because if you look at most of those studies, especially the ACCORD, I'm going to go back to the ACCORD study. If you go look at the ACCORD study and you do meta-hoc analysis, you will see that if you go a blood pressure below 120, actually your stroke risk will be lower. And this is confusing. يعني بصير يجي المريض and the patient will be coming to our clinic, will say, and we'll ask him which organ you want to prevent the damage. your brain, your heart, or your kidney. And it doesn't make sense, because when you see a patient with diabetes, you treat him as a whole, and you need to individualize the patients. So what I did, I looked at all the studies who did a meta-analysis, and those are a meta-analysis on most of the studies, and came up with this fair statement. I think we all need to lower the blood pressure to 130/80. Especially in patients, which majority of our patients who have atherosclerotic risks, meaning dyslipidemia, obesity, hypertension, of course, and smoking, family history of coronary artery disease, all of them will add the risk. So you need to lower to 130/80. Of course, you follow your patients. Why I am worried about lowering the blood pressure? And it's the same worries that we all have. Lowering the perfusion to any organ, the kidney, the brain, and the heart. Well, you have to follow your patients. If your patient's been given an added medication to target a blood pressure of 130/80, and he tells you, doctor, I feel dizzy, or you examine him and there is orthostatic hypertension that's increasing, then you need to lower the blood pressure. Of course, you can follow the perfusion by simple exam, or test, which is renal function. Rise in serum creatinine, hyperkalemia can be a part in the low perfusion stat. So I would suggest that you individualize your patient. And I think the recommendations of the guidelines was clear, but this is what was added in the ADA guidelines. If you have an addition of atherosclerotic disease, then you will have to target your patient less than 130/80. Hopefully, we're talking about the same page, and there was no much of a differences. Okay. Treating hypertension. Of course, I'm not going to go over lifestyle modification, blood glucose control, but we'll talk about medication and as a nephrologist, our understanding of the core treatment in patients with hypertension, because there are new medication on the block that we're going to be talking about tomorrow. But it's still, for us as a nephrologist, the core treatment is RAS inhibitor. And the reason, because this is the hypothesis that we believe. We believe that patients in type 1 and type 2 diabetes, especially in type 2 diabetes, they may present with micro and macroalbuminuria that precedes the presence of diabetes or discovery of diabetes. And this has been proven even with kidney biopsy. The patient presents with proteinuria, and then after a while, he will develop the diabetes. So you'll have diabetic nephropathy early on. And that could be the main reason why this patient is having hypertension. So there is a defect in the glomerular system that activates the RAS system. Of course, this has been proven by many studies showing that if you increase the angiotensin, you actually can increase the pores of the glomeruli and increase the leak, as you can see here, the radius or the molecular radius of the glomeruli, increase the leak of proteinuria and adding up to the hypertension per se. Of course, the ACE inhibitor is the drug of choice, or ARBs, RAS inhibitors is the drug of choice in diabetic patients. There are many studies have shown this. I'm not going to go over all of them, but as you can see, if you give ACE inhibitors like captopril, you can lower the blood pressure compared to other medication. Most of the control medication were calcium channel blocker. And of course, there is a better overcome in the overall mortality and morbidity, especially on the kidney disease, doubling of serum creatinine and albuminuria. And this is, again, the Rhine Core study. And this is another study by Dr. Lewis, who actually suggested even beyond blood pressure control, even if you have same blood pressure, beyond blood pressure control with ACE inhibitor and ARBs, that lowers TGF-beta and the glomerular disease in those patients. Another part is the ARBs, which I included the IDNT irbesartan study. And the irbesartan have shown that if you actually compare irbesartan to the control, which is amlodipine as a calcium channel blocker, then you will see the benefit. And that benefit is add-on if you increase the irbesartan meaning more inhibition to the RAS system. So the more inhibition to the RAS system, you actually can do much better with the outcome. The other question is, which medication should we use? Angiotensin converting enzyme inhibitor versus ARBs. And to be honest with you, there are too many answers. It depends which society you belong to. If you talk to the ADA society, they'll tell you, well, ACE inhibitor is better off with type 1 diabetes, ARBs, and type 2, you can use ACE and ARBs. And to be honest with you, I think they're all the same. I believe if you have a patient with uncontrolled hypertension, uncontrolled diabetes, meaning significant hyperglycemia that fluctuate, then you're probably better off giving ARBs because of the lower risk of hyperkalemia. But again, I'll leave this up to you. This is one study called the detailed study. They looked at the enalapril and telmisartan, and both of them showed that there is no added benefit on both of them. Now, I just want to stop and talk about one thing, that ACE inhibitors and ARBs, the new suggestion that you don't have, the new guidelines suggest that you don't have to start ACE inhibitors or ARBs in patients who doesn't have microalbuminuria. I don't agree with this. I think you still have to start ACE inhibitors and ARBs early on if you have hypertension, even without ACE inhibitor. Of course, it depends on which book you're reading, which study you've been reading, but I think ACE inhibitors and ARBs, as a nephrologist, we have good enough documents to see that if you start ACE inhibitors and ARBs early on, that it can actually delay the appearance of microalbuminuria. And this has been documented by Dr. Ramuzzi, Dr. Lewis, and even in animal models that actually can reverse the disease process in the kidney. Anyways, what about dual blockage? CALM study. We all know that the CALM study looked at candesartan and lisinopril. Of course, you had a better blood pressure control, you have a better blood pressure, decreased serum, doubling of serum creatinine and decreased microalbuminuria. But are we recommending it? The answer is no. And the reason, of course, the hyperkalemia and the acute events. So would I recommend that? No. There are specific cases that you would recommend the dual blockage, that if you have severe proteinuria and you can't do anything, and you know that this is related to diabetic nephropathy. So dual blockage is not an indication. You have only specific indication for it. The ADA put the hypertension guidelines, and I'm just going to summarize that. I may not agree with it 100%, but if you have a patient with a blood pressure that you found that his blood pressure is systolic, less than 160, and diastolic less than 90, you can start with one medication. But if you have it higher than that, you can do with two medications. From my limited experience, that this doesn't work. Most of our patients, especially in type 2 diabetes, they are resistant type of blood pressure medication, So I think they ought to start with two medication. I don't think so. There is a harm on that in that regard, especially when you combine ACE and diuretics or ARBs and diuretics. Okay, and this is just one comment because this is from the ADA. If you look at that consideration, that you refer the patient to a specialist in the high blood pressure, I believe you are the specialist in hypertension. You deal with this more than we do. And adding like aldactone, I think you have to be careful, especially when the patient on ACE inhibitors. A lot of studies have shown that they increase the risk of hyperkalemia and acute injury. So I don't think so this is a valid answer, except in severe, resistant, or refractory form that we'll talk about later. Again, this is the new drug on the block, SGLT2 inhibitors. They suggest that it can actually lower the blood pressure. It seems that it's going to be available in water. I think the reason it drops the blood pressure, and actually it's important, in it has improved patient with congestive heart failure because it does diuresis, glucosuria, and you'll get diuresis. So it's not a major breakthrough, but this is one reason why we have to follow those patients, especially on ACE inhibitors, not to get into acute kidney injury or dehydration. But this is one medication that been reported that lowers the blood pressure. Okay. What about resistant hypertension? How frequent we see patients with resistant hypertension? And what's the diagnosis? And what's the diagnosis of hypertension resistant? Well, it is when you use 3 medications, including thiazides, and you don't get to the target. That doesn't mean that a non-compliant patient, but meaning that you are following that patient, you're giving 3 medications, including thiazide, and it's not getting to the target. So what do? You need to consider of secondary causes. One of those causes in regards to nephrology is atherosclerotic disease, and the other one is glomerular disease, especially if you have proteinuria or hematuria. Of course, other secondary causes that will be followed by the endocrinologist. Refractory hypertension. How frequent do you see a patient? You give him too much medication and you cannot control the blood pressure. We've seen it. It's been reported that 2 to 3% of the patient with diabetes have refractory hypertension. And the assumption that it is sympathetic driven, even you give them high dose of beta blocker, you still see this patient with a heart rate of around 90 or 85. At one point, sympathetic denervation was thought to be the solution, but the outcome results was not enough to suggest that. So one thing that I use, it's not evidence-based, don't take it as a hard copy, but I've been using muscle relaxant. I know it's different. This is smooth muscle and this is skeletal muscle, but I'm using relaxone in some of those patients. It seems that it helps lowering their blood pressure. What about digital transformation? Okay, I think this is a huge subject. I don't think so I have enough time to talk about it, but I think because I do attend the startups in the Silicon Valley and I see the amazing work that they've been done. But one important aspect is in blood pressure. There is not enough. I mean, look at the guidelines and the data that we have. It is conflicting. And the reason, because our results dependent on the human and the human error. And the environment that the patient takes the blood pressure. If you ask the patient to go with the Holter monitor for the study, the ambulatory blood pressure control, just knowing that you have something on your hand that gives you anxiety and will give you a false reading. When you go to the office, that nurse may have a bad day and will give you the false reading. So now there is a new gadget on the block, which is a small transducer that is it's a patch that I think will be approved by the FDA soon, similar to the one patch that you have for diabetes. And actually, it depends on the waves, the ultrasonic waves from the artery, and give you accurately the blood pressure. And that would help to transform and probably to to change the way we think of hypertension. The studies will be different. So because you will take second by second blood pressure measurement, of course. And the biotechnology or biotechnological and biomedical transformation. Of course, we know part of them اللي هي renal denervation, the paraflex activation therapy, carotid body ablation, and of course the renal artery stenting. But what's important, and this is a new concept, is curing hypertension. Now I know this is different, this is strange, because look what we've been doing in the last probably 20 or 30 years. We've been doing a great job on controlling the blood pressure. And we've been doing a great job decreasing the cardiovascular event. But to control the blood pressure, the compliance is still an issue. And the other thing is we did not do well job in preventing hypertension. So the question, can we cure blood pressure? Well, this is something called RNA interference. And the concept behind it is the RNA interference.
Okay, so you have 3 minutes.
Okay, thank you. The RNA interference is actually an RNA that actually degrade and damage the messenger RNA. Okay, هذا مش على السريع. Okay, so this is the RNA. So this is the mRNA. The RNA interference actually damaged that mRNA. So there will be no translation to the protein. So you will have gene deletion or gene degradation. So you won't present or you can degrade the hypertension gene. And this is a promising therapy. And this is gene editing. Again, this gene editing, actually somatic gene editing of the PCSK9, this is a protein that actually been associated with the cholesterol and hypertension. And if you manage to delete or change this gene or this protein, you actually can interfere with the appearance of hypertension and actually cholesterol. Anyway, thank you. I'm sorry that probably I confused you with too many slides, but thank you again, and I'll be happy to take your questions.